Okay, good evening, everybody. Welcome to this another session of pericardial diseases. And last few of the lectures before we finish this online training program for this 46th comprehensive course on echocardiography. I'm going to deal with this pericardial diseases today, trying to explain you in nutshells what is pericardium, what is pericardial effusion, then pericardial fat, effusive constrictive pericarditis, and pericardial effusion. Once we finish the lecture, we'll have a question answer session before we close. And then we'll have some views from all of you who are attending this session. So I'll move forward on talking of disease of pericardium. Well, in pericardium, we have to understand what is systole, what is diastole. When we are talking of a systole, we should talk of a pericardial ventricular system, not a systole. We'll be talking of a ventricular system. So if I'm talking of pericardium, I'm talking of systole, it means I'm talking of QRS T complex, beginning of Q wave and end of a T wave. If I'm talking for diastole, I'll be talking of end of a T wave to beginning of QRS complex. Because the systole and diastole, they are applicable for both the structures, LA as well as LV, RA as well as RB. Here is a pericardium. Here is a heart. Heart has been enclosed by a pericardium, which has got two parts, visceral and parietal pericardium. The visceral one is inner one, outer one is parietal pericardium, and there's a potential space in between this pericardium, which has got some amount of pericardial effusion, and this is known as pericardial cavity. So when we'll talk about pericardium, we may come across a time when we talk of intrapericardial pressure, like pericardial pressure right into the pericardium between visceral and parietal pericardium, and intra-heart pressure, like pressure in the right chambers or left chambers. So that's what we'll be dealing about when we talk of hemodynamics in pericardium. Now here is a pericardium. If we start talking about pericardium, this is echo image, this is CT image. This is one modality CT which supersedes echocardiography as far as pericardial evolution is concerned. Which we can't see in echo, we can easily be seen in CT of the heart to look for pericardial thickening or effusions. Now comes to the question of what is pericardial thickening? What is acute pericarditis? What is pericardial effusion? And then what is effusive constrictive pericarditis? So we'll be going in sequential fashion, one after another one. Okay. Here is the word which is known as pericardial thickening. Pericardial thickening is, we go to subcostal view or a plaques view to look for a pericardial thickening. The most glistening part of the pericardium, which appears to be thicker and calcified, is seen like this over here. And same thing can be seen very easily in CT or MRI. Here is a pericardium which is thicker. Any thickness more than 5 mm is considered as thickened pericardium. Look at the thickening of the pericardium. This is LV posterior or LV free wall. It is inferior or inferior posterior wall. Behind that, that is a pericardium which is present over here. And it's definitely more than 5 mm on thickness. And very important thing which we often listen when we're doing echocardiography is, we talk of an epicardial fat. We talk of a pericardial fat. And these epicardial fat as well as pericardial fat, they are the surrogate markers for coronary atherosclerosis. And amongst them, the most important part is the epicardial fat. Here is a picture of the same thing. Here is the LA LV and RV, and on top of that, between the two spaces, the pericardial fat is present. This is known as epicardium fat. And the fat present outside the pericardium is known as intrathoracic or a pericardial fat. This fat is surrogate marker for atherosclerosis, but this fat is not a surrogate marker for atherosclerosis. So we have pericardial thickening, we have epicardial fat, and then we have intrathoracic fat. And now look at this particular phenomena, which is seen in virtually all of our cases. What we see when we look at this echo has got this so-called a potential free space. This potential free space could be anything. It could be effusion, it could be thickening or a fat. And that's what we need to look at it. Now, this is thickened pericardium along with pericardial effusion in between. Look at the thickening of this pericardium. One side of visceral, another side is parietal, and there's significant effusion in between. So this patient has got a pericardial effusion along with thickened pericardium. And this is like organized fat into the pericardium, which is known as epicardial fat, and this is intrathoracic fat, which is present outside the pericardium. We can not only see in subcostal window, we can only see them also in apical four-chamber view. Here is an apical four-chamber view. This is in between two pericardial space, and this is outside the pericardial space. That's what we look at when we do an echocardiography in day-to-day practice. So if I have to sum up, there is epicardial fat, pericardial fat, pericardial fat, perivascular fat, ectopic fat, and a visceral fat. But we are what is concerned is the epicardial fat and a pericardial fat. And its category says mediastinum outside the pericardium, which is also known as intrathoracic fat. Sum of epicardial and pericardial fat is known as pericardial fat. So we look at epicardial fat, we look at intrathoracic or pericardial fats. Next things comes, how do we look at a pericardium in day-to-day practice? This is the busy slide, so I'm not going to go in detail of this. We look at the basic investigations, ECG, XH chest, and complete blood count is ESR and metabolic panels. And we try to hear a murmur, which is idiopathic pericarditis. And this idiopathic pericarditis could be because of many reasons. Apart from idiopathic, it could be post-surgical, it could be post-trauma, it could be a complication of a chronic kidney diseases. Many reasons are there when the pericardium gets swollen, and we must see this particular phenomena during our COVID time also. And what they need, they just need a simple management. On the other hand, they go to a complicated courses, like they develop effusive constrictive pericarditis, and many of those things when we use other modalities or imaging modalities to prove them. What is acute pericarditis? Most common pericardial syndrome in clinical practice is diagnosed based on two of the following criteria. One is a chest pain. Pericardial friction rub. All of us, I'm sure, that know of pericardial friction rub is a continuous friction rub. Characteristic ECG changes, new widespread ST elevation or depression, and presence of pericardial effusion. And this could be a minimal or smallest amount of pericardial effusions. Supportive findings, we always look at inflammatory markers, which are significantly increased, including of polymorphonuclear leukocytosis and ESR, C-reactive protein, and other inflammatory markers. Etiology is multifactorial, and we have seen this in many times during the last 3 years of our practice. Virology. Tuberculosis is quite common in our country still. And differential diagnosis comes in various things, like we can develop pericarditis for many reasons. All of us understand why we develop a pericarditis in other conditions also. ECG changes, look, in comparison to acute MIs, the ECG changes are not dome shape, they are curved shape or convexity upwards. And this could be seen practically virtually in all leads, may not be selective as shown in this. This is seen in lead 2 over here. It's seen somewhere in AVL, not in lead 3, not in AVF, but seen in V5, V6. And if you don't look at them carefully, we always land up making a diagnosis of acute myocardial infarctions. So going further, coming to pericardial effusion, the pericardial effusion could be asymmetrical with clear separation across all the pericardium. Or it could be more echogenic area anteriorly and none posteriorly. If that is true, then it's not a pericardial effusion, it's a pericardial fat. Now look at this image very carefully. My heart in plaques view, LA, LV, and aorta. Here is a LV mass. Here is a pericardium which wraps around the LV. But this pericardium stops short of descending aorta. And when they stop short of descending aorta, what we see a pericardial effusion present over here just before descending aorta, but the pleural effusion extends beyond the descending aorta. And here is an example. Here we see not a pericardial effusion, this is pleural effusion because it's extending beyond the descending aorta. So this is the most important markers to differentiate between pericardial effusion as well as parietal pericarditis. Pericardial effusion and the pleural effusions. Here is an example where this fluid is stopping just short of descending aorta. As the pleural effusion is there, it will extend beyond the descending aorta to differentiate between pericardial versus pleural effusions. How much of pleural effusion, which is most important thing, is small echo-free space less than 1 centimeter, which gives rise to almost 100 ml of fluids. Moderate is 100 to 500 ml, 1 to 2 centimeter of echo-free space. Large echo-free space, more than 2 centimeters, is considered as large pericardial effusions. And many times, what people ask us, what the question is, where do we see a pericardial effusion? Now this picture is talking about plaques window, but the most common place where we look at the pericardial effusion is subcostal window. Here's the subcostal window, and here we look for separation of the pericardial effusion from parietal to visceral pericardiums. So if you happen to look this kind of a phenomena in a clinical practices, always try to look first at subcostal windows. Causes, most common cause, I said in COVID time was COVID pericardial effusions, that post-operatively infective, traumatic, malignants. But the important thing is, recognition is important, but the most important thing is hemodynamic effects. Somebody has got a pericardial effusion, how does it make a difference? We can tap it up, know a diagnosis, treat it. But if somebody has got a pericardial effusion along with tamponade, that's the most important time to interact, to intervene. And that's how we need to do it at that time, is to look for causes. What are the most common causes for pericardial effusions? I've already, most common cause of pericardial effusion, and on top of that, when to quickly intervene in this subset of population, because that is the important time. I've already told you about pleural and pericardial effusions. Pericardial stop short of descending aorta, and the pleural extends beyond the descending aorta. Here's a pericardial effusion, and here's a pleural effusion. We look at all windows: parasternal, subcostal, and apical, small, moderate, large. And another important part is diffuse versus loculated. Look, pericardial effusion cannot be always present on uniformly around heart all the times. It could be loculated in certain pockets, like when we have a high protein contents like exudates. They try to organize and give rise to a loculated pericardial effusions. So there you have to really look for a pathophysiology and have to act accordingly. Moving on from pericarditis to pericardial effusion to tamponade. This is the most important part of any exercise in pericardial effusions. Now, what I said in the beginning is tamponade occurs when the intrapericardial pressure exceeds pressure of the cardiac chambers. I hope I'm able to say these words very correctly. The difference, now the hemodynamic is dependent on the presence of intrapericardial pressure because of pleural effusion versus the pressure in the chambers, whether it could be right or it could be left. And now what is my RV pressures? They are approximately 25. What is my RA pressure? They are approximately 5 to 10 millimeters of mercury. What is my LV pressure? Almost 20 millimeters of mercury as my systolic blood pressure is. What is my LA pressure? Is almost 10 millimeters of mercury. So my pericardial pressure, intrapericardial pressure has to be more than intracardiac chambers pressures. So if you look at the pressure changes, if you look at all four chambers of the heart, which is the most susceptible chamber of the heart is, if you look at the pressures, it's RA. Because RA has got the lowest intra-chamber pressure as compared to RV, LV or LA. If my intrapericardial pressure goes up more than RA pressure, if it's more than 10 millimeters of mercury, the collection of fluid rapidly or slowly, whatever it is, but goes more than 10 millimeters of mercury, it will push an indent on right atrium. And when this happens, that's what we call them as pericardial tamponade. The pressure still go on more than 25 millimeters of mercury. So it indents RV. So when that happens, this is known as pericardial tamponade. My pressure has to be more than 120 millimeters of mercury to compress my LV, and it has to be more than 10 millimeters of mercury to compress my LA. But LA does not have a membrane at all. So we are not looking for LA. We are looking for RA, RV, and LV to compress because of increased pericardial pressure. Now, this two slides tell you two different things. Pericardial pressures versus pericardial volume. Here is pressures versus pericardial volume. The gist of these two slides is the pericardial tamponade happens with which the rapidity with which the pericardial fluid collects. If my rapidity of fluid collection is very high, like collects very quickly so that intrapericardial pressure reaches more than intracardiac chamber pressure, we'll always land up with what? Pericardial tamponade. Second thing is, all these things leads to what? The impaired filling of the LV and RV. And when the impaired filling of LV and RV is present, it leads to a pulse pressure differences, which will come in a couple of minutes. So, pericardial effusion leading to intracardial pressure more than 15 millimeters of mercury, cardiac compression with reduced filling of right and left heart chambers, increase and equalization of intrapericardial right heart, and diastolic and pulmonary capillary wedge pressure, decreased cardiac output and BP with increased heart rate and pulmonary vascular resistance. What are the findings? If I've got a very high pericardial, if I've got a high pericardial pressures leading to tamponades, what will happen? There'll be a fall of blood pressure because filling would not be adequate. My neck vein will engorge, my IVC plethoric will be present. And on top of that, when I take a deep inspiration, my pulse on the other hand, because of left ventricle interdependence, that will disappear completely. So one of the causes for pulsus paradoxus being a pericardial tamponade. So High venous pressure increasing on inspiration, small pulse pressure decreasing and disappearing on inspiration, underlying pericardial disease, and accurate diagnosis require integration of clinical echo and hemodynamic data. Determinants of pericardial tamponade: very large pericardial effusion. It's not the large, it's a rapidly collecting pericardial effusion. Very dense pericardial effusion means what? More exudative. And the last is high intrapericardial pressure, because these pressures will only be determinant of pericardial tamponades. Whether large pericardial effusion or rapidly collecting effusion or dense pericardial effusion, they all lead to a high intrapericardial pressure, compressing RV and RA to begin with to produce pericardial tamponades. So what are the findings? What we look in pericardial tamponade is, now here the word comes classically when we talk of systole and diastole. RA systolic collapse more than 1/3 of duration of systole. Mind my word, RA always collapse during diastole. That's atrial contraction. When this collapse happened during diastole, that's during QRST complex, beginning of Q wave to end of a T wave, and lasting for almost 1/3 of its duration, this is known as pericardial tamponade. If it has happened to RV, it has to happen during diastole, because RV fills during diastole and contracts during systole. So reverse, it has to contract. It is collapse, which is seen during diastole, is known as diastolic collapse. On top of that, what exactly happens? There should be a reciprocal changes in the volumes. Why the reciprocal changes in the volume is because heart is enclosed in large fluid and it cannot expand. When it cannot expand during inspiration, when the large volume of blood comes to the RV and RA, the interventricular septum bulges towards LV. That is known as ventricular interdependence. So what exactly happens? If you take an inspiration, the increased fluid respiratory variation would be more in inspiration. The flow would be more in inspiration and RV, but less in LV. And during inspiration and expiration, when you have a respiratory changes of more than 25%, then you talk of pericardial effusion. I'll show you all these things one by one. And another important thing is reduce early diastolic tissue Doppler velocity. I'll show in a couple of minutes. And most important thing is IVC plethora. Let's stay one by one. What is IVC plethora? IVC plethora is when IVC does not collapse at all with inspiration. Here is an inspiratogram. And here is the beginning of a QRS complex to end of QRS, beginning of another QRS complex. So if you take, like, there's no change in IVC, that is what is known as IVC plethora. Second, RV systolic collapse or RA systolic collapse more than 1/3 of its duration. How do we look at it? We always put a cursor across this RA. Look at an M mode, switch on our respiratograms, and then hold our image to scroll on this pattern, how much my RA collapse is present during systole. And we look at the systolic pattern over here. Same thing, we look at a diastolic pattern over here, whether in diastole RV collapse is happening or not happening. Then this is a picture of RV diastolic collapse, which is happening during diastology or end of a T wave to beginning of QRS complex. This is what is known as ventricular reciprocal respiratory changes. How these are? This is a respiratogram. This is expiration and this is inspiration, right? With inspiration, the flow in RV and LV will change. Normally what happens when we inspire, the RV flow will increase, but LV flow will reduce. Here, this variation should be more than 25%. In each of these cycles, whether we are looking at RV or LV, this is a picture of LV filling. Look at the maximum flow velocities over here and the minimum flow velocities over here. Can we hold on for a second? Just give me a sec. Somebody's calling left and right from a hospital. Just give me a sec. So this respiratory variation is more than 25%. So what we look, we put a sample volume at mitral or tricuspid valve. We switch on this respiratory This is inspiration. So this is inspiratory wave. This is expiration. This is expiratory wave. So we measure the maximum of this, and this variation should be more than 25%. As you see over here, we measured almost 81 and 69. This is not exactly 25%, but we look at more than 25% of respiratory variations. Then increase RV filling first bit of inspiration. Let's look at this particular phenomena. What we look at, don't let's just give it up. Let's look at the respiratory variations both in RV and LV. And here is an example when we have this LV collapse because of large pericardial effusion. It's not only collapsing the RV and RA, but it's also collapsing the LV also. It means the intrapericardial pressure is more than 25%, more than 120 millimeters of mercury. This is one word which is very, very important. And we often see this kind of a thing when we imagine or when we image these people in 4-chamber view. So what exactly happens? What does it mean by? This is a classical picture which is shown over here. When we inspire, the volume of the RV will go up. And since heart is enclosed in large pericardial effusion, it cannot expand. So this septum will bulge towards the opposite side. And when we expire, this septum will go to the other side and giving rise to a ventricular independence phenomenon. So in nutshell, what we should see that with inspiration, there's a decrease in the velocity of left-hand side. With inspiration, there's an increase in the velocity of right-hand sides. And this respiratory variation should be more than 25% to talk about the pericardial effusion. Clinical findings: low cardiac output, elevated venous pressure, pulses, paradoxes, hypertension. That's what I told you. If I have to gist up all these in echo findings, moderate to large pericardial effusion, even small also, I'll not say no to it. RA systolic collapse, more than 1/3 duration of systole. RV diastolic collapse, more than 1/3 of duration of diastole. Reciprocal respiratory changes in RV, LNV volume, that is ventricular independence, and RV plethora. Doppler, respiratory variation in LV and RV diastolic fillings, increase RV filling on the first beat after inspiration, and decrease LV filling on the first beat after inspiration. Again, back to almost the same thing. We need to have these respiratory changes. Patient is in shock, small pulse pressure, underlying pericardial disease, and we look at an echo to make an accurate diagnosis. And I'm repeating that slide again and again. The determinants of pericardial tamponade is not the amount of fluid, is the large amount of fluid. If it's collecting very rapidly, even the small can lead to a pericardial tamponade. And very dense pericardial fluid consisting of a lot of proteins inside, like exudate, is also a determinant for pericardial tamponade. And all these leads to very high intracardial pressures, leading to compression of RA and RV and LV in some very rare cases, leading to pericardial tamponade. One thing, everybody makes a mistake. As soon as somebody sees a pericardial effusion, they'll try to give an Lasix or diuretics to these subset of populations. When they try to give Lasix or diuretics to these subset of populations, obviously what happens? The intracardiac chamber pressure falls down further and the tamponade gets aggravated. So this is a condition where we need a lot of fluids to increase intra-chamber pressure rather than decreasing them. And the choice of treatment would not be a Lasix or furosemide. The choice of treatment would be infusion of the fluids in this subset of population and then doing a pericardial drainage. Moving on to the last modality for today, that is effusive constrictive pericarditis. We started the thickened pericardium, we moved to pericardial effusion, then we moved to pericardial tamponade, and now this tamponade effusion have got organized to lead to constrictive pericarditis. So the long-standing pericardial effusion leading to constrictive pathology, that is known as constrictive pericarditis. So what exactly the most important part for constrictive pericarditis is? Thickened pericardium, and it may have a fluid in between or may not have a fluid in between. This is a plaques window. Just put a cursor across this plaques window. Look, this is separation of the fluids. And on top of that, you can look at the thickened pericardium. So what will happen? It will have all the features of pericardial tamponades. But apart from that, it will have few more of the feature of constrictive pericarditis or effusive constrictive pericarditis. What is those features? One, I showed you thickened pericardium. Respiratory variations will be seen as it is. They're not going to be changing the respiratory variations. And on top of that, there will not be collapse of any structures in these subset of population because the fluid has converted into a constriction pathology or a shell kind of a pathology. So all those things what you hear in tamponade would be seen in pericardial constrictive pericarditis or effusive constrictive pericarditis. What else we see in these kind of a thing is 2 or 3 very important things what we see in this effusive constrictive pericarditis. One is the most important feature is tissue Doppler imaging. We put a sample volume in tissue Doppler at septal inverse as well as lateral inverse. Normally, septal velocity E prime is more than E prime, less than E prime of the lateral inverse. But in effusive constrictive pericarditis, the septal E prime will become more as compared to lateral E prime. Here is 9 in the medial annulus, and look, here is only 4 in the lateral annulus. Normally, it's a reverse, and that's why it's known as annulus reversus or paradoxic septal paradoxus. You can have a large fluid or thickened pericardium. IVC plethora will be as such. They're not going to change in the IVC plethora. All those findings, apart from that, would be important. Third important part of effusive constrictive pericarditis is one is thickened pericardium. Second is tissue Doppler imaging of septal lateral annulus. And third is a hepatic venous flow. Look, in normal all circumstances, whether systole or diastole, there is constant flow of hepatic vein to IVC. Here is systole and here is a diastolic wave and small reversal. But in constrictive pericarditis, what exactly happened? The first beat at end expiration or beginning of an expiration, you will find a reversal of flow into the hepatic veins. And this is known M-shaped pattern. When we see a reversal of flow from IVC to hepatic vein, and that happens during expiration. So we have a respiratogram. Normally, go back to a previous slide, is all lower down, very few complexes or one, like 2 small complexes seen over here, which is seen at the end of a QRS complex. But in this, you'll find this M-shaped complexes in constrictive pericarditis or effusive constrictive pericarditis. And when you say they are very pathognomonic of effusive constrictive pericarditis. Here is an example of normal versus reversal of flow in hepatic vein in the first beat of expiration. So findings, thickened pericardium with or without pericardial effusion, reciprocal respiratory variations, RV and LV volume, changes in flow patterns, IVC plethora, hepatic venous flow, that's the most important thing, and a septal lateral annulus. Velocity. So apart from pericardial tamponade, we do not see any compression of those structures, but we look at a thickened pericardium with hepatic venous flow pattern as well as septal E prime and septal E prime at septal annulus or the lateral annulus. This is how we differentiate effusive constrictive pericarditis from pericardial tamponade. And number of times this effusive constrictive pericarditis is transient because the patient has migrated from pericardial effusion to effusive constrictive pericarditis. Again, repeating the same things: pericardial thickening, normal alveolar size, raleigh enlargement, flattened diastolic wall, abrupt posterior wall of the ventricular septum, and dilated IVC and hepatic veins. So in nutshell, that's what I wanted to tell you about pericardium, starting for thickened pericardium, pericardial effusion, then tamponade, finally going to effusive constrictive pericarditis. I put a stop over here and take up your questions, what all you would like to ask for today's